So nostalgia from seeing Koilonaikia bedside to getting taught with CLL. Long journey, same condition although for me.
Tushar, I'm really glad to see you at this stage. Matlab, I still remember you as my intern. And now you are at a
Hi.
very high, Kunal.
Hi, sir.
Hello, Kumar. Hi. How are you?
I'm fine, sir. Good, good.
Wonderful. So everyone can hear everyone clearly, right?
Yes, yes.
Wonderful. I guess we're waiting for Dr. Biswa. Then I guess Sadamni's mic issues getting solved then. So quite a good session. I guess session one is also very well. All the updates have been covered. We will see. And the second case is also very challenging, very not very commonly that we see. And the outcomes and suspicions are quite difficult. So I guess there are many DM residents and DNB residents also that will be joining. So we'll focus on teaching good points regarding the same for them as well. Right. So Roshni, are there any more technical glitches to be handled? We have 2 more minutes. Then we will go.
Sorry, sir, I just missed it.
So we have 2 more minutes. Our technical glitches have been solved regarding Dr. Saudamani.
Yes.
Just we can do one mic testing for her as well before we go on.
Uh, ma'am, Dr. Saudamini, ma'am.
Am I
Hi.
audible?
Ma'am is calling me.
Ha, Saudamani, can you hear us?
I can hear you. Can you hear me?
You are very clear. You can sing a song also very clearly now.
I don't want to sing right now.
Great, great. Now I think issues have been solved. We're just waiting for Dr. Biswa, then we will start.
So Dr. Bhuyan will be joining in a couple of minutes. Could we start the session, sir?
I think we can start. We are on time.
Okay,
Okay.
sir.
So, yes, yeah.
So very good evening, everyone. A warm welcome to all the participants joining us for today's IIO Expert Insight session on Hemato-Oncology. And I'm Roshni from IIO. I'll be your host for this evening. This session is organized by International Association for Integrated Oncology, IAIO. We are delighted to have us an exceptional panel of experts who will share their insights on chronic lymphocytic leukemia, exploring current evidence, real world challenges, and future innovations in management. To set the tone for the evening, now I would like to welcome our program director, Dr. Tusha Pandey, director and head Raghav Institute of Hematology, Uttarakhand, to deliver the welcome note and introduce the scientific theme of today's session. Over to you, sir.
Thank you, Roshni. Thank you for the wonderful introduction. Now, I welcome everyone to this session. This session is very special because we have lots of great experts and faculties with us here. Now, we all know that CLL remains to be one of the most dynamic and ever-changing areas in hematology. With initially we are having a good chemoimmunotherapy, now moving towards a chemo-free regime, to data and studies coming every day, every month. So this session has been divided into two parts. Session one, where we see all the basic theory as well as all the updates pertaining to CLL and its management, followed by a wonderful session two, which will be a real life complications that we see while managing a case of CLL. Before moving ahead, I would like to introduce our guests for the session today. Starting with the speaker for the session one, I welcome Dr. Varun Bafna. Dr. Varun Bafna is a hematologist and hemato-oncologist. He is the dietitian head at Star Super Specialty Hospital, Kolhapur, Maharashtra. He's board certified in hematology, hemato-oncology, and trained in bone marrow and stem cell transplant. I welcome you, Bafna sir. Then I welcome Dr. Sodamini Mahapatra, who is assistant professor at the Institute of Medical Sciences and SUM Hospital, Bhubaneswar, Odisha. And her areas of expertise include hematology, hemato-oncology, and bone marrow transplant. Welcome, Dr. Sadamini. Then we have two special hematology experts for the session. I welcome Dr. Kunal Goyal. Dr. Kunal Goyal, MBBS, MD, and DM in clinical hematology, heads the Department of Hematology and Hemato-Oncology at the Kokilaben Dhirubhai Ambani Hospital, Navi Mumbai. His areas of expertise include hematology, hemato-oncology, bone marrow transplantation, and CAR-T therapy. Welcome, Dr. Kunal. Thank you for your time. Then we have Dr. Biswajit Bhuya, who is assistant professor at the Kalinga Institute of Medical Sciences at the Department of Hematology and Hemato-Oncology. He's a hematologist and hemato-oncologist and has vast experience in complex transplant procedures. I welcome you, Dr. Biswajit. Now, with that, I would like to hand over the torch to Dr. Bafna and request you, sir, to please start with the session one. Over to you, sir. Sir, please unmute yourself. Your video is clear, so you just unmute. Yes.
I'm audible now?
Yes, you are.
Yeah.
Please go ahead.
Tushar, thank you for a warm welcome and a great introduction and I'm really thankful for IO for inviting me to have a small discussion on CLL updates. And I remember still Tushar as my intern long back in 2010, 2011. He's a very gem guy from the day was really the day I came to know he's completing his hematology course. And I know we have a good discussion many long time. And I welcome all the other faculties, renowned faculties here. With that, I'd like to start today's topic. We'll be try to just see what are the updates in this current year and what are we expecting in future. CLL update, what it is, when, and what's ahead. This is all the consensus we are going to discuss. Just to brief, CLL, it's an indolent disease. For all the PGs who are around, it's a slow growing leukemia lymphoma. It's a mature B cell disorder, basically accumulation of clonal B cells in the peripheral blood, bone marrow, and or lymphoid tissues. The symptoms are most of the time it is asymptomatic but may develop B symptoms, cytopenias, are painful or disfiguring adenopathies with organ dysfunction. And what is the goal of care? To prolong the survival. It's a non-curable disease at present. To control the disease progression, improve quality of life, minimize the symptoms, and to manage for the adverse events of the therapy. Let's see statistics wise, the estimated cases in the 2025 was around 23,690 with the estimated death is around 4,500. The median age of the diagnosis is still around 70 years, but in our country, we might see around 50 years also, 50 to 60 years, you can say. Median age of the death is 82 years. And there is no symptom, no treatment, even for the high risk patients at present, we are just monitoring. What were the indication for therapy? It's a significant disease related symptoms like fatigue, ear drenching night sweats, unintentional weight loss, fever with no infection like type B symptoms all, a threatened end organ damage, progressive symptomatic or bulky disease where the spleen is more than 6 centimeter or the lymph node size is more than 10 centimeter, progressive thrombocytopenia, anemia, or steroid refractory autoimmune cytopenias. These are the places where the therapy has to be introduced for these cases. For the overview of diagnosis, as we are aware, CLL is a mature B cell leukemic and a leukemic form of small lymphocytic lymphoma. They are now recently categorized as pre-neoplastic or neoplastic small lymphocytic proliferation, that is MBL, and CLL and oblique SLL. Always B cell origin it is, can progress to TCLL, now TPLL or BPLL no longer as recognized now. So we'll try to see that. And diagnostic requirements is more than 5,000 clonal B lymphocytes should be there in the peripheral blood. That should be sustained for more than equal to 3 months. That has to be, the clonality has to be confirmed by the flow cytometry. Cytopenias due to the marrow infiltrates, diagnosis of the CLL regardless of the B cell count. In the blood smear, as everybody is aware, we look for the small mature lymphocytes that is admixed with the pro lymphocytes if it is there. Yeah, more than 55% if it is a pro lymphocytes, it favors the B pro lymphocytic leukemias. And the smudge cells, what we call as a Gumprecht shadows, that is a characteristic feature in the peripheral blood. For the diagnostic algorithm, in the peripheral blood, as you have discussed, it should be more than 5,000 B cells for lasting for more than 3 months. Flow cytometry, the important param points CD5, CD19, and CD23 with low surface Ig that confirms the clonality. The smear wise smudge cells, yeah, mature lymphocytes, supportive. No nodes or cytopenias. If there are less than 5,000, still it is can be possibility of MBL. Nodes plus no leukemic phase, it could be on biopsy preferred that diagnosed as a SLL. So these are the guidelines according to which how we have diagnostic for the CLL patients. To look for the prognostication with the CLL IPI, it is basically incorporates into the age. Rye or Binnett's clinical stage still remains because of this upcoming all the mutations. So Rye and Binnett, we have to go ahead with the CLL IPI, serum beta 2 macroglobulin, IGHV mutational status and TP53 mutational status to stratify patients into 4 risk groups: low risk, intermediate, high and very high risk. You can see here the variable parameters with the factors. Age cutoff is a 65. If it is more than 65, you have to calculate as a score +1. Clinical stage BC by Binet or Rye 1 to 4 +1. Serum beta 2 microglobulin, if it is more than 3.5, it's a +2 here. And the main two things what we have noticed here is a IGHB mutational status. If it is unmutated, +2, it goes in the high risk categories. TP53 like deletion 17p or TP53 mutation, it's a +4, has to be taken here. So how they calculate an overall survival? Low risk overall survival as shown here is a 93%, intermediate as 79, high risk is 63, or very high risk is around 20 to 23% only. So initially for the low risk, no need to treat. Intermediate, no need to treat except if the patient is symptomatic. High risk, treat except when the patient is symptomatic. And very high risk, treat in experimental protocols with non-cytotoxic drugs if possible, no chemotherapy or chemoimmunotherapy. Role of NGS is mainly for TP53, Notch, BIRC3, SF3B1 or ATM mutations. So these are the guidelines which has been coming up with the NCCN guidelines in the latest 2025. Recommended first line therapy for the CLL. Now the preferred agents we can see here clearly. Now we are coming up with we are going away from the immunotherapy, chemotherapy, and we are going towards BTKI or BCL2 or CD20, that is usually immunotherapy type. Acalabrutinib with or without obinutuzumab, zanubrutinib, venetoclax plus obinutuzumab, or venetoclax with acalabrutinib with or without obinutuzumab. If we are dealing all the cases without 17p or TP53 mutation. And other thing is venetoclax or ibrutinib in the second line, or ibrutinib also can be thought of options. And in the last, if there is some mutation in the IGHV or the FCR, can be still thought of if the clinical condition ECOG performance status is good. If it is unavailable, few options still like old, what we have to do is a Benda-Ritux, chlorambucil obinutuzumab, and the other chemotherapies which is mentioned here. With the deletion 17p or TP53 mutation, still most of the drugs with the BTK comes in the upfront only. It could be with or without obinutuzumab. Zanubrutinib has been shown some of the promising result, but not very great. Venetoclax with obinutuzumab, venetoclax with acalabrutinib with or without obinutuzumab, and the other option as we have discussed. There are a lot of lists available. Whenever you go for any of the food to have, you have many options, but we have to choose. We can't eat everything now. CLL dynamic monitoring versus treatment. Never treatment is close to 33%. Treatment at or near diagnosis will be requiring 33%. or progress to treatment is around 33%. Most of the patient with CLL will require this therapy. So let's be rational and let's try to discuss. What are the indications as we have seen? To be more specific, disease-related symptoms, fatigue can be tricky. Progressive bulky disease with the spleen more than 6 cm or lymph node more than 10 cm. Progressive bone marrow failures with anemia, thrombocytopenia, if not responding to steroid, that is anemia. Autoimmune anemia, the complications in there, a hemoglobin should be less than 10 gram or platelet should be less than 1 lakh. Progressive lymphocytosis, that's a lymphocyte doubling time is less than 6 months or increase in more than 50% in 2 months. So the absolute lymphocyte count alone, not an indication for the treatment. To selecting the right treatment, we have to see for the key parameters, how to choose. 5 parameters: clinical stage, symptoms, fitness and comorbidities, especially cardiac and renal. With the new upcoming drugs, we should be sure before we proceed. Genetic risk with 17p, TP53, IGHV. Our treatment line and prior responses. Additional factors you can see of co-medications, that could be anticoagulants or CYP inhibitors, because we'll try to see with some of the agents, BTK cannot be used because it's a little bit risky for the bleeding disorders. Patient preferences, whether it is a fixed duration versus indefinite. Economic consideration, definitely in our country has to be considered. Our goal should be fixed duration, then to look for the undetected MRD or treatment-free intervals. So these are the novel agents which are superior to chemoimmunotherapy in the first line. There's a lot of list and different trials we'll try to discuss individually now. Let's say according to NCCN guidelines, this is the latest published in 2025. What we have first line therapy, this is without 17p or TP53 mutation. As we have discussed, BCL2 inhibitors containing regimens are like venetoclax with obinutuzumab or venetoclax with acalabrutinib with or without obinutuzumab. Covalent BTK inhibitors based regimens are acalabrutinib or zanubrutinib. That could be with or without obinutuzumab. So other first line is again the same. If first which is failed, you can try with the other regimen. Certain condition rare, we'll try to see with some of the clinical trials in upcoming slides. First line of treatment, it's a 4 primary options. Continuous therapy with covalent BTK inhibitors. That is a basically acalabrutinib and zanubrutinib. Recently approved as zanubrutinib, which is available in our country now. Time limited therapy with BCL2 inhibitors combination. It's venetoclax with obinutuzumab, which was approved in 2019, and venetoclax with acalabrutinib. Approval it's still pending, but many people have started using it. The interesting thing is time limited here. Technically, there are 6 options, but I rarely add obinutuzumab to acalabrutinib or venetoclax plus acalabrutinib. Factors guiding the therapy. Does your patient prefer time limited therapy? If yes, then venetoclax with obinutuzumab is a complete in 12 months. Venetoclax with acalabrutinib is complete in 14 months. This is a very interesting if time limited therapy. These are new guidelines which are upcoming now. Does your patient wish to avoid infusions? Then you can go with the covalent BTKI or venetoclax plus acalabrutinib, or all are oral drugs. Does your patient have underlying bleeding risk or significant cardiac disease? Consider avoiding covalent BTKIs. Does your patient have significant underlying renal impairment? Yeah, increased risk of TLS, may avoid venetoclax with obinutuzumab and opt for covalent BTKIs. Does your patient have deletion 17p or TP53? Covalent BTK appears to control disease better than the time limited options. Acalabrutinib, it's a second generation covalent BTK inhibitor, more selective kinase inhibitors with very fewer adverse events. It's highly effective. Activity appears comparable with ibrutinib. Overall response rate is 90% and 5-year PFS is 72%. Equally efficacious in IGHV unmutated versus mutated. It's better tolerated, which we'll try to discuss in the Elevate RR trial. And it have shown less arthralgia, myalgia, hypertension, or fibrinogen, bleeding risk is comparatively better. Does cause headache? Yes. Caffeine helps here. FDA approved in 2019. It's a drug, everybody is aware, it's 100 mg per oral BD, can combine with obitizumab. This is a Elevate TN trial, that's a PFS with 6 years of follow-up. Here it has been clearly mentioned, you can see here. A plus O versus O plus chlorambucil. O is here obinutuzumab, N is acalabrutinib. You can see here the median PFS was 78%, and overall survival has not been reached till now. Median PFS is again not reached in the other second arm and third arm, where there is a obinutuzumab with chlorambucil. The PFS was only around 27 months, with 17% as only the response. After median follow-up of 75 months, median PFS was significantly longer in the acalabrutinib containing arm compared to the obinutuzumab with chlorambucil arm. These are the all recent mentioned treatment options and the trials which I'm going to discuss. Second generation, that's a zanubrutinib, that's a covalent BTK inhibitors. It's a more selective kinase inhibitor, very few adverse events, highly effective, superior to BR in first line CLL. First, one study suggests more active than ibrutinib, that's an alpine trial. Overall response rate is 98% and 5-year PFS was 76%. It's equally efficacious in IGHV unmutated versus mutated. It's better tolerated than ibrutinib. It has less atrial fibrillation, bleeding, and diarrhea. Similar risk for hypertension and is FDA approved recently in last Jan 2023. Its dose is 160 mg oral BID or 320 mg once daily. Sequoia 5 years follow-up trial with the zanubrutinib versus bendaritux. You can see here PFS in overall population. In the bendaritux, you can see here it was definitely decreased. You can see here median PFS was only 44 months, and in zanubrutinib it has not reached till now. It has been continued. In PFS in the IGHV mutated state, if you can see here, in the bendaritux mutated, it was very less. It was around 35% only PFS. Zanubrutinib, if in the mutated cases, have shown 17. Bendamustine unmutated have shown 61, and zanubrutinib unmutated was around 23% PFS events. So mutated and unmutated, we see overall the results are much better with the zanubrutinib as compared to the bendamustine rituximab. In the CLL14, the 6-year follow-up, with the PFS with the venetoclax with obinutuzumab versus chlorambucil with plus obinutuzumab, it was a time limited, very interesting trial. Now the CLL18 is ongoing. We'll see for the 14 which results are out, which was published in last year in ASH 2024. The PFS you can see here, very good. Median PFS wise, venetoclax with obinutuzumab was 76 months, chlorambucil obinutuzumab was 36, and PFS for 6 years percentage was around 53%, and chlorambucil obinutuzumab was 20% only. PFS had by TP53 and IGHV mutation state. Again, the difference easily can be made out here. Venetoclax with obinutuzumab, TP53 deletion and mutation, with IGHV mutated and unmutated, with obinutuzumab, the results are not very great. So, prognostic factors in venetoclax obinutuzumab arm, where the deletion 17p, unmutated IGHV, and lymph node more than 5 cm, independently associated shorter PFS. So, you can see here, if there is any mutation, BCL2 inhibitors with immunotherapy of CD22 antibodies are not going to help that great as compared to BTKI. In the Amplify study design, there's a pre-specified interim analysis, international randomized open phase 3. It was published in 2024 ASH. I think this year they will completely come up with these results. How they are conducted: adult with previously untreated CLL requiring treatment according to the criteria as we have discussed. There was no deletion, 17B TP53, performance status was good. And we can see here, they have kept the 3 arms, that is AV, the ACAL, venetoclax, ACAL, ven, obinutuzumab AV arm, and FCR or BR arm, whichever is used by that institute. Primary endpoint was to look for the PFS and secondary endpoint with different outcomes. So PFS was overall, with the AV arm was around 83%, with the AV was around 76%, and the FCR or BR was 66%. This was all absence of TP53, 17p deletion or unmutated IGHV. Study met its primary endpoint demonstrating significantly proportional PFS as per the IRC for AV versus FCR or BR after median follow-up of 48 months. Overall survival, if you can see here, Again, AVO has a better compared to the BR-FCR. Overall performance was much better. This was study conducted with the during also COVID, so they have compared that during COVID-19 deaths also. Amplifier has also seen for the rate of undetected MRD in a peripheral blood by the flow cytometry. This was a very interesting first study who was looking for the MRD. In this population, in the treatment at the secondary endpoints, what they have noticed, you can see here the timing of the key secondary endpoints was at the 12 weeks and timing of the end of the treatment without was 28 days windows. And the PFS with the, as we have compared to the median on the basis of mutated and unmutated IGHV, and they have seen with the MRD also. Overall result in the PFS, if you can see with the MRD, that has not reached in AV and AVO arm, and that has reached in BR was around 49 months. So clearly we can mention out here कि even if you want to define the time period, I think the MRD will be down the line, will be definitely helping us when we can stop the treatment if the MRD is negative for certain period or what. In CLL14, the PFS and the overall survival with the first line obinutuzumab with venetoclax or chlorambucil, that is a time limited here study. What they have seen here, again the ven obinutuzumab and chlorambucil obinutuzumab, you can see here progression free survival, that median observation time was for around 76 months, and the PFS you can see here in the ven obinutuzumab was arm much better as compared to the chlorambucil obinutuzumab arm, and overall survival are also much better and not reached in venetoclax obinutuzumab as we have seen in the chlorambucil obinutuzumab. Which therapy is the best initial therapy in CLL? See, this is always a point of discussion with the different trials which we have discussed. Resonate ibrutinib 70% at 5 years. You can see here the very good results. Its Amplify has clearly mentioned with the IGHV mutated acalabrutinib venetoclax 86% at the 3 years, or unmutated they have seen acal venetoclax with 69% at the 3 years. Follow-up was the CLL14 has also shown a promising result, and Amplify with the acal ven obinutuzumab 84 and 83% at 3 years. What to do with all these great options? The covalent BTK inhibitors recommending to older or frail patients with a CLL, simple and safe, indefinite therapy, less an issue. Recommending if TP53 apparent, data is impressive. Acal versus zanubrutinib, essentially never add obinutuzumab. Time limited if option you want to choose, it is recommending if IGHV is mutated, results comparable to the indefinite BTKI. IGHV unmutated and young age, conversation with the patient regarding the pros and cons. VO versus AV versus AVO, discuss pros and cons with the patient. Do not see myself recommending AVO at this time. How do we choose an upfront treatment? From the first line of therapy, symptomatic or advanced disease, what is our protocol, what we try to follow? This is from the AJH journal recently published for CLL updates 2025. All fit and unfit. Venetoclax obinutuzumab fixed 1 year. Acal, zanubrutinib as a monotherapy you can go, or venetoclax with BTKI. Deletion 17p, TP53, no to chemoimmunotherapy, BTKI with or without venetoclax, consider allo transplant at second relapse. Good fitness with mutated IGHV and plus no TP53, FCR only if target agents unavailable. Fitness no longer limits novel agent use. Monitor cardiovascular risk with BTKI, tumor lysis or renal with the venetoclax and obinutuzumab. Now NCCN what say for the second line therapies? As we have told, the preferred regimen is BCL2 inhibitors like venetoclax based regimen. BTKI can be used if initially not used, acal, zanubrutinib. And non-covalent BTKI, this upcoming pitobrutinib, I think at present not available in India, I think will be available soon. Suggested treatment regimens with 17p deletion is chemoimmunotherapy is not recommended. Again, the same line BTK, BCL2 with different combination as we had discussed. So the sequencing of the novel therapies in CLL, not all relapses are created equally. This will continue to evolve as more patients are treated with only novel therapies, and sequencing questions will change too. In the relapse post CIT, if the relapse post Covalent BTK plus anti-CD20 monoclonal antibodies, you have to change that BCL2 or BTKI in sequence. If it is a relapse post BCL2 with CD20 monoclonal antibodies, you can go relapse post BCL2 and you have to change alternate as mentioned. Key biomarkers testing to inform relapse refractory prior to treatment initiation. You can see here if assess for 17p fish TP53 NGS, reassess for the 17p you have to do. Test for BTK and G2 mutations may be useful. IGHV does not need to be repeated. This you have to keep in mind. These are the different pivotal studies upcoming. Studies with the different median, will not try to go in detail. Ibru plus rituximab versus FCR was another discussion for the untreated CLL. Same again, the results were almost the same as we'll try to the main core of discussion. PFS after ibrutinib discontinuation. This was interesting. Relapse of ibrutinib, markers matter, and the time on the treatment before the therapy was definitely a matter, which was initially. So you should be aware whether it was 17p, 11q, 12. So it was better seen in the trisomy 12 and 11q deletion. Rest all the it was not a great if you stop the BTK inhibitors. BTK inhibitors as head-to-head, this alpine trial, zanubrutinib versus ibrutinib, they have shown zanubrutinib I have seen as a comparatively better as 65% as PFS as compared to 54, and with or without 17p deletion, slight better improvement. What they have seen overall response in zanubrutinib was 85 as compared to 75 in ibrutinib arm. Venetoclax based regimen in previously treated CLL. What we can see here clearly, venetoclax with rituximab, median PFS was around 54 months, and with a good overall survival as compared to the only BR arm. So median overall survival from the initial treatment was not reached, and from the treatment was 7.1 year. The outcomes with the venetoclax retreatment, as once you start, you can retreatment. Outcome is overall response rate of around 80% with the median PFS of 25 months. In the Murano study, they have seen around 72%. Median PFS was 23 months, and the complete MRD was undetected in 32% of the patient only. So these are the novel therapies as the sequence we have tried to discuss now. What we take home we can do with it, repeat first line if remission is off. If remission was for 3 to 4 years with the first line therapy, you can repeat that. Switch class if it is an early relapse within 3 to 4 years or 17p deletion, you can switch. As we have seen, if it is a BTKI first line, second line go with Venritux or non-covalent BTK. When obinutuzumab initially used, repeat if more than 3 years of remission, or BTKI with or without anti-CD20, or chemoimmunotherapy BTKI with or without anti-CD20, and Venritux or obinutuzumab as Murano trial. Relapse after covalent BTK and BC12, it becomes a challenge for us. It is always difficult, and the results are also not great. You can see here clearly mentioned it's a relapse refractory. You have to either enroll in clinical trials. CAR-T is upcoming. Non-covalent BTK are another option, or allogenic transplant. Let's try to explore that. It's a chimeric CAR-T therapy. Lisocabtagene is an approved drug. With it, approved CAR-T therapy which is available, or non-covalent BTK can be used, pitobrutinib, which is at present not available in our country. Other recommended regimens are PI3KI based regimens, that is dualisib, idelalisib. It has its own side effect and many issues. Lenritux, somebody is trying in our country when there is no finance or concern. Bendaritux, FCR is still another option. So these are the different studies. Pitobrutinib has now patients are recruiting and the studies are ongoing. Results are looking promising. Let's see how it comes down the line. Captivated FTO cohort retreatment after the progression of the disease with the first line of the ibrutinib venetoclax. You can see here the complete remission is very less in both the arm, around 5% or 14%, and progression and partial response is around 80% and 57%. CAR-T, everybody is aware, it's adaptive immunotherapy in the clinic. Now everybody, most of the hematologists are aware. We just collect the WBCs, including the T cells are separated out and rest of the blood is returned to the patient. T cells are sent to the lab. For the manufacturing, T cells are engineered to the target and kill cancer cells viral vector to express the CAR. And then in the body, it is injected back with after the lymphodepleting chemotherapy. and then it causes tumor cell death, and that remains in body for some times to help prevent new cancer cells from growing it. So this was a Transcend CLL-004 tumor burden correlated the overall response in the clinical trial. And this you can see here for the which has been approved. They have shown this is a lisocabtagene maraleucel with the ibrutinib. That's so interesting. In relapse refractory, they have used BTK and the results were much better. You can see here response rate, overall response was around 86% with the CR of around 45%. Median PFS was 31 and median OS has not been reached. With the any grade of CRS, more than grade 3 was only 4%, but rest 80% has CRS, but it was only grade 1 or 2. And it was all one curable and treatable. So third line and double refractory, how you can go with it's a poor prognosis, but still PI3K inhibitors like idelalisib with rituximab or duvaciclib, it's a limited use. CAR T therapy is a promising and trial access is still on. Allogenic transplant has curative intent and high risk. Chemo alemtuzumab, hardly we use in India now. Rechallenging the prior therapy is possible if resistance mutation has been lost. The treatment evolution is CLL, modern CLL paradigm. It's a past chemotherapy, long remission in fit mutated IGHV, but now it's a targeted and fixed duration. We are targeting the MRD to be undetectable, and future will be MRD directed duration cellular therapy. The key message will be fixed duration, and with the MRD undetected and the quality of life tailored by the genetic fitness and prior responses. Just last few slides to complete for the emerging therapeutic approaches. BTK degraders are there because we will find down the line BTKI inhibitors resistance, and these enzymes degraders are going to help. These are many drugs in the pipeline. Will not go in detail at present. NX-2127 for treating the patient relapse refractory. All are in the phase 2 trial mostly. And results are looking quite better. This is a bexobrutideg in the B cell malignancies. Again, it's again the phase 1AB study of the patient in the relapse refractory B cell malignancy, more than 2 cell line, prior use of BTK and BCL2. They have mentioned, they have used, and the results are responses. 13 patients with the response are more than 6 months and 5 remains on the treatment for more than a year. Promising results, many drugs in the pipeline we'll able to see. Cadence 101, this is another trial, BGB 16673. Relapse refractory, will not go in detail. This is all the ASH last year published. Let's see this year what all will come. And these are the with the different drugs what they have seen it. Bispecific antibodies, just to enumerate, mosunetuzumab, glofitamab or epcoritamab. Glofitamab is available, but it's very costly and used. We have to just import it at present, and results looks okay, fairly good, but we have to use again along with it some other drugs. These are the results of the drug of the trials. What has been come up with the Epcure CLL for the epcoritamab. It's a bispecific antibody binding to CD3 on T cells and CD20 on B cells. It's again the phase 1b2 stage. It's a long journey. Primary endpoints was look overall response, CRS and ICANS and TLS. What they have seen is evaluable for outcomes and overall on PFS. Median PFS was 12.8 months and median overall survival with the 70% and has not been reached now. The safety wise quite better, same like the other drugs. CRS and ICANS are the still thing we have to just manage with the tocilizumab and other drugs which are available. Last, to conclude the current challenges in what we are facing, there's an uncertainty and sequencing of the gaps. There should be optimal sequencing of novel agents that are not established. Real world data, registries and retrospective. Ibrutinib better than idelalisib as the first kinase inhibitor. Post ibrutinib failure when followed by idelalisib or chemo. Post venetoclax failure, ibrutinib best salvage. Still we need a randomized sequencing trials. It's a MRD undetected. It will be a treatment free survival, and fixed duration combination can be just seen with it. You can see here with all the different MRDs has been mentioned in the trial. So durable of treatment remission, we have to monitor with MRD that will help us down the line. Fixed versus continuous therapy. In the clear CLL 17 trial, head to head, what they have seen, ibrutinib continuous monotherapy, when OB is fixed duration of 1 year, and when Ibru is fixed duration 14 months, not very clear. Again, goal is for deep remission and with control of the disease. Targeted agents always will dominate the relapse CLL, second line targeted, followed by the chemoimmunotherapy. And we have discussed in detail for all the other drugs. Enhancing cellular therapies, it's a very good. You can see here ibrutinib more than 5 cycles, decrease PDA1 on T cells, decrease CD200 on CLL, and increases CAR T expansion and function. See, patient who has received ibrutinib, no concerns with the CAR T getting. So clinical studies are using Ibru plus CAR T, increased response tended to deeper remission, what we have seen close to 86% versus CAR T alone, because they have a synergistic effect that kinase inhibition leads to immune restoration. Emerging challenges will be double refractory CLL, and then experimental therapies like non-covalent BTKIs, CAR T bispecifics, allo and non agents in the trials, and relapse inevitable, cure remains still elusive. Future directions, dynamic CLL, we have to see, include patients in the trials. Biannual guidelines have been updating. We have to very closely see that for the guidelines which are upcoming. And MRD guided duration, I think that will be down the line future for CLL patients to prevent clonal evolution and achieve cure in subset of patients. CLL therapy is evolving fast, so stay current and enroll in the trials, and this you have to just be updated with the guidelines whatever are coming yearly. Thank you very much for giving opportunity and having a small discussion. Hope I have tried to finish in time.
Well, thank you so much, sir, for such an illustrative and such an apt discussion and about all the updates of CLL. And for the residents who are watching, I guess the points like importance of CLL IPI, that comes very important when you explain how the prognosis of the patient will be before starting the treatment. And factors guiding the therapy that sir has showed is one of the most important parts of clinical practice. The why to select, and majority of the times it's the patient who decides what therapy he or she wants. Now, wonderful, sir. Thank you so much.
Yeah,
Just to
thank you,
save the
Vikram.
time, just to save the time, we will move to the session two, and I'll hand over to Dr. Sadamni. But before handing over, Dr. Biswa has joined us. I welcome Dr. Biswajit Bhuyan, who heads the Department of Hematology at Kalinga Institute of Medical Sciences, Bhubaneswar. Welcome, sir.
Hi,
And
good evening. Good evening. Thank you. Thank you for the.
so, Dr. Sadamni, all over to you. Please, you can start this.
Thank you, Vishal. Thank you, sir. It's a wonderful session. I think after your explanation, it will be easy for me to go through my case. So let's just start. Is my screen visible?
Yes.
So I think Dr. Kunal and Dr. Vishwajit are there with me, right?
Yes.
Yeah.
Okay, let me start. A 62-year male who presented with a chief complaints of dyspnea on exertion for 1 month, fever with cough and expectoration for 20 months. On examination, he just have tachycardia with a temperature of 100.4 degrees 4 degree Fahrenheit, and he had only mild pallor with no ictus, no lymphadenopathy, and no hepatosplenomegaly, with a comorbidity of only benign hyperplasia of prostate. On routine investigation, the CBC showed his hemoglobin was 7.1,
The
TLC was
slides are not
57,000
moving.
with a lymphocyte predominance.
Dr. Sadamni, your slides are not moving.
And I think make a full screen.
Um, I did, sir. I think I'm able to move it from my side.
Have you
I think
shared
there's
your
some
screen?
network issue. Is it visible now? Yeah.
Slides are visible, but they're not changing. Can you start the slideshow, or I think it's not started, something like that.
Is it visible now?
Yeah, now
Yeah,
they are
now it's
changing.
moving. Yeah.
Yeah, yeah.
Okay. So should I restart?
I think from the case presentation, just with the indices you had.
Okay. So just like I said, it was a 62-year male with presented with a chief complaint of dyspnea for 1 month and fever with cough and expectoration for 20 days. On examination, he had tachycardia because of fever, as his temperature was 100.4 degree Fahrenheit and mild pallor only. No lymphadenopathy, no hepatosplenomegaly. On routine investigation, his blood count shows a hemoglobin of 7.1, TLC count of 57,000 with a lymphocyte predominance, and his platelet was 1,43,000. The peripheral smear comment shows an absolute lymphocytosis with the presence of a smudge cell. We did a DCT, which was negative, vitamin B12 was negative, iron profile with a ferritin of 4 and T-set of 12 suggestive of iron deficiency anemia. His chest X-ray was also normal. I would like to ask my panelists how would they have approached to such cases. Dr. Kunal, can you take the question?
Yeah. So this patient has is a case of CLL with infections. So first of all, in this case, I would like to start with the antibiotics first. Let the patient start with the antibiotics and see. In general, whenever these cases are there, I usually prefer the biofire, respiratory biofire, because most of the times they have viral infections. It saves time rather than having a blood culture which is mostly 20 to 30% times positive, and then based on that biofires modify the therapy, make the patient stable, and then you do a baseline CBC and the investigations that are required for CLL, the test, and most important, immunoglobulin levels. Suppose these patients have lower immunoglobulin levels, supplement with IVIG, and then go ahead with the further history. If the patient have recurrent infections, if the patient has indication to treat according to IWCLL criteria, and if it is there, then we start with the treatment for CLL. If it is not, then and it's a single isolated infective episode, then we can observe for this patient.
Actually, we did the same. As per the IWCL 2018 criteria, we just did the CBC and a flow cytometry from the peripheral blood only. And this was the flow cytometry which showed a positivity for CD5, 23, and 19, and it was dim for CD20,
Dr. Sadamni,
279.
sorry
And
to
we
interrupt.
made a diagnosis of.
Yeah, we are just able to see how do you approach this case slide. It's not visible. Your slides. Can the
Okay,
team
is it
can
possible for the
the
team to?
Roshni can you,
Yes, sir.
show the slides if
We
it's
are
possible?
doing so.
Madam can just dictate from there. Yeah. Yes. So we can go from the slide. How do you approach a slide? That is, I guess, five or six. Fifth or sixth one. Yeah, from the sixth slide. Yeah.
Yes. No, not this one. I think that's my old slide. Uh, Dr. Tushar, I have shared my recent slide with you. Is it possible
Yeah,
for you?
that's that one only. It's that one only.
No, I don't think it's the same one.
Okay, can you move to the next slide? Roshni, Dr. Sadamni can see.
Is this the slide, sir?
So now Dr.
Next
Sadamni can
one.
see next to her when.
Next. No. This is not the one. Okay.
This is the final film. Hope the screen is visible, ma'am.
It is visible to us. Yeah.
Kindly let me know when the slide is.
Next one. Next one. Stop it over
Yeah,
there.
perfect. Yeah.
So, am I audible also?
Yes, ma'am.
Yeah, okay. So we run the flow cytometry from peripheral blood itself, and it showed a positivity for CD5, 23, and CD19. It was dim for CD20, 279 D. So with a flow score of 4 points, we made a diagnosis of CLL. Next one. We also did the genetic and the molecular studies, which show a cytogenetics of 47XY with a trisomy 12, and he was positive for TP53 mutation with IGHP mutated, and FISH for CLL was positive for deletion 17p. Next one. So just like sir has already discussed, when how should we approach? How should be our approach when it comes to treating a CLL, and what will be your approach in particular case? As Dr. Kunal has already said that if it requires, first we have to treat the infection, and if it requires some treatment for the CLL, we have to go for it. Next one. And also one said, if the patient is in stage 3 of address the infection part, and we can keep the patient on an wait and watch condition. The next one. So our diagnosis for this patient was CLL with an iron deficiency anemia with TP53 mutation. Staging was to be done after we see the response to iron therapy because the patient has an iron deficiency.
So Damni, your voice is not audible.
Is it audible now?
Yes, yes.
Yeah. So we made a final diagnosis of CLL with iron deficiency anemia with TP53 mutated and trisomy 12. The staging has to be done once we see the response to the iron therapy. Roshni, next. Next. So we have started the patient. We have started the patient on iron therapy, and we have asked him to be on follow up with the CBC, and also we have added him on the antibiotics. But within the next 1 month, patient developed a fever of 1 month, vomiting of 4 episodes, and a headache of one day. And he directly landed up in the ICU. Next. We also planned for some MRI, but because of some of his old fracture, he was not able to undergo some MRI. We did a CSF study at that time also, which showed only neutrophilic phagocytosis, and he was managed as conservatively at that time. Next one. But subsequently, again in the next month, the patient developed and he complains of inability to walk and an altered sensorium for 2 days. Next one. But this time, when we did a CBC, his hemoglobin was 12, TLC count was 32 with a lymphocyte of 54%, TPC was 131. We also did a blood culture which showed no growth, and the NCCT head showed small vessel ischemic changes and diffuse cerebrocerebellar atrophy, and the EEG was suggestive of encephalopathy. Next. But the patient developed sepsis and went into the septic shock and was intubated. We did this time also we did a CSF study which showed a TLC count of 1,200 with a neutrophilic phagocytosis. In view in suspicious of this CLL infiltration, we also did the flow cytometry in the CSF, which showed no clonal lymphoid cells. But the cytology of the CSF was suggestive of some fungal capsulated organism. So we did a streptococcal antigen assay, which was positive. This was an Indian ink which showed on the background there was some organism which with capsulated organism with the halo around them, and the cryptococcal antigen was positive. Next. So my question to Dr. Vishwajit will be: with such a recurrent infection, what will be your approach for such a CLL patient?
Okay, so like in a patient of CLL who gets this type of recurrent infection, So these first things we have to check whether the patient is getting adequate prophylaxis for pneumocystis and antiviral or not. So we generally do give acyclovir and bacterial prophylaxis for all these things. And the next step would be to definitely check for an immunoglobulin levels, and in patients who have means less than 400 and with a clinical scenario of recent infection, so we can give him IVIG for the same. So that could be means an approach. At the same time, we also try to vaccinate this group of patients, so not during chemotherapy, but during means other period. And third, and sometimes we do give this myeloid growth factors like filgrastim. So when there is very severe means neutropenia. So I think all those factors means all those steps can means elevate this means issue of hypogammaglobulinemia in CLL.
Sir, actually, we did check the immunoglobulin levels, but the immunoglobulin levels were in the normal side, actually. So we didn't
Right,
plan
right.
for the IVIG. And one more thing, sir, like in such a deadly opportunistic infection, do you plan to start the therapy also?
Yes, yes. So means there means definitely along. So in this case, so means that I was actually generalizing, but specifically in this case, the patient has got a CNS fungal infection. So we do treat with amphotericin B liposomal specifically, and flucytosine is there, but it is.
Like, do you want to address the CLL part also?
Yes, yes, but not at this point of time. So we generally do treat this infection first, followed by this chemotherapy or BTKs for CLL.
Okay. Next one, Roshni.
Dr. Sodamani, one question just. In the past one, where before this event, he was presented with headache and fever,
Yes, sir.
as you have told. At that time, what treatment we have started for that, and what was
Sir,
have you
actually,
worked up for a fungal and
so no, yes, sir. We did the cytology at that time also, but it was just showing a neutrophilic pleocytosis. It will suggest any type of organism in that. So we have just managed conservatively with IV antibiotics actually. So he was managed, but
okay. So all yeah, any other workup we didn't able to do it.
no, sir. Actually, because of some constraints, we were not able to work up for other fungal. But this time, when he subsequently presented, because last time when we gave the IV antibiotic, he was okay. So we thought, yes, okay, it was just a bacterial infection because in CLL, I think bacterial infections are most common. So we did that and left him for the home. But within 1 month, again, he developed the weakness and an altered sensorium. So this time, this time also the cytology of the CSF showed some capsulated organism. We initially thought it might be contamination because last time CSF was absolutely normal. But this time, that for that reason only, we did the Indian ink and also we did the cryptococcal antigen assay, which came to be positive, which made us like, okay, that might be an opportunistic. That time also, he might have fungal infection.
Yeah, so fungal infection is not that common in CLL patients. We means generally don't see this kind of scenario. Means very rarely we do see. So means definitely a case to means report like.
Rocky, next one. So yes, this is the guidelines. As sir has already said, the IWCLL guidelines and the NCCN guidelines when to start the treatment for this patient, which states that whenever there is significant disease-related symptoms like fatigue, drenching night sweat, uncontrolled weight loss, fever without any infection, certain end organ damages, progressive symptomatic bulky lymph nodes or splenomegaly, progressive cytopenias, and steroid refractory and autoimmune cytopenias. I think in that we should uh, be working up that recurrent infections also should be included to start the therapy. Next one. Yeah, so what was challenging for us that the final diagnosis was CLL with a VNet stage A, right stage 0 with only BHP, and there was a history of fracture. And his trisomy, he was trisomy 12, positive for trisomy 12, CP53 positive, IGST mutated with a CLL IPI score of 9. with the opportunistic infection in the form of Cryptococcus neoformis. Next one. Like I already asked, what was your line of treatment for the particular case? So what will be our next line of treatment for this particular case?
Yeah. Is it directed to me?
Yeah, yes, you can do it.
Yes. So this patient has TP53 mutation. So we know that outcomes are poor. If patient is affording and they have all the money in this world, I would have started with zanubrutinib. It has a better data in terms of TP53 mutation as a lone monotherapy. Here, in this case, I would start with acalabrutinib because the cost is low, relatively low, and once the patient stabilizes, the infection part is taken control of, then I would have added this venetoclax as well with rituximab in the later part, if at all needed. But rituximab again, there is a risk of infection, so acalabrutinib and venetoclax I would continue for some time per se. 6 months at least. When I have given venetoclax for more than 6 months, there is a long prolonged cytopenia, which I have observed in many cases, and this also further increase the chances of infections, especially reactivation of TB, which I have noticed in two patients. And there was a recurrent cellulitis that happened with venetoclax. So even the combination in Indian scenario, it is not so easy. So 6 months of venetoclax and azacitidine, if it is feasible, then later on continuation of acalabrutinib till progression. That would be my strategy in this patient. Affording zanubrutinib.
This time his TBC showed a hemoglobin 12, TLC count being 30,000 with a lymphocyte of 54. So I think disease was under control, but still you will prefer venetoclax and
Yes,
acalabrutinib.
he has TP53 mutation, so he's a very high risk patient. So you need to treat.
Any
Yeah.
other opinion from my other panelists?
So definitely I do agree with this things like TP53 mutation. So actually this BTK were means inhibitors should be incorporated in the first line. But venetoclax, so it doesn't work really good that for this TP53 mutated. So we can consider in our settings a combination of rituximab plus acalabrutinib. So that can be a decent combination. And if the patient relapses, of course, we have to go for this allogenic transplant also.
Thank you. Next one, Roshni. Yeah, so first, as sir has said, we have first managed the cryptococcal infection, which, as per the IDSA guidelines, we have which advises to start him on liposomal amphotericin B with dose of 3 to 4 mg per kg daily and a flu cytosine 25 milligram per kg 4 times a day. Next one. So we have started him on injection ambisome with a 5 flu cytosine, which was actually not available. So we have started him on fluconazole for 2 weeks, which has to be continued for 12 months. However, the patient's condition rapidly deteriorated and required intubation with a vasopressor support. Slowly he responded, and after 7 days of antifungal therapy, we have started him on acalabrutinib 100 mg OD as a definitive therapy. Now, after hospitalization of 38 days, he was being discharged on acalabrutinib 100 mg OD and a fluconazole 200 mg BD for 2 months, which has to be followed by 200 mg OD for the next 9 months. Next one. Roshan, next. Okay. So I would like to ask how many of your CLL patients usually present with infection? As we know, infection in CLL is a very deadly complication. So how many of them present with infection, and if infection, how many of them present with fungal infection? Dr. Vishwajit, if you can take this one. Hello. Roshan, the previous one.
To
Hello.
have you
Doctor,
directed the question, Dr. Sudamini, to Dr. Biswajit?
if Dr. Kunal is there, he can take my question.
Yeah. So in general, I think 10 to 20% of the patient present with the serious infections. Most of the times they are incidental finding, and out of them, with the fungal infections, very few. I have seen less than 5% in my practice with the fungal infection upfront with the CLL. It is very rare. Even in my uh, when I was doing my DM and other in Tata, the presentation with the fungal is relatively rare. They have bacterial infections upfront, especially URTI and pneumonia. They are very common, but it is also in 20% with the upfront settings, most likely. Rest of the cases, I feel they are incidental finding in my practice. There may be a bias uh, in place when there's less healthcare awareness and all these things are there. You may get around 40 to 50% of the patients present with the infections and fungal infections.
Yeah, that's
They do
actually.
actually. They do most of the times. They many times they present with cutaneous infections also, specifically those who are from the like village areas and not well to do. And many times with yes, pneumonia is a very common presentation. And many of our consultants are from the pulmonology department that are incidentally found to have lymphocytosis.
Yes, actually, they present with bacterial pneumonias mostly by the encapsulated organism. Fungal infection is a very rare one. Which prophylaxis do you prefer, sir? Actually, you prefer it to whenever the patient is being diagnosed with CLL, or only in cases the patients require the treatment, you start them with prophylaxis. Varun, sir, if you are there, you can ask, reply to my this question. Varun, sir is not there.
Okay, so prophylaxis, we can, means if the patient is undergoing treatment, we do give prophylaxis. Sometimes if the patient, sometimes we do, means even if the patient, when there is relative neutropenia, and still the patient is stage 1 or 2 also. So prophylaxis, I think there is no harm in giving prophylaxis to asymptomatic patients also.
Roshni, the next one. So now, sir, any difference in the opinion? Even I think the NCCN guidelines also said that only and the infective prophylaxis has to be given during the treatment or thereafter if they tolerate. And the prophylaxis they prefer is for herpes virus to give the acyclovir, and for the PGT for the sulfamethoxazole trimethoprim. So I think hepatitis B and everything only when the patient is being required with the therapy they are being asked to start with the entecavir first. The next one. So do you regularly immunize? Do the immunization for your patient? Kunal sir,
Yes, we generally immunize. I mostly immunize with pneumonia, pneumococcus, influvax, herpes, and Minectra mostly with all those four things mostly. And then in a COVID, previously we used to do also check with the COVID infections as well. Generally, four infections we generally take. Most of the times, because of the cost, people are able to take influenza and pneumococcus. That is bare minimum, I believe.
next one, Roshni.
And in addition to that, you need to check immunoglobulin level. If the immunoglobulin levels are low, then you give IVIG and then vaccinate.
Okay.
One question to the house. If we check, assess the immunoglobulin levels, what is the ideal time? We got questions there in the chat box as well. So we're asking, should we go upfront or should we at the time of diagnosis or after a few months of therapy or follow up? What is the ideal time to assess that?
I believe at the time of diagnosis, we should check immunoglobulin level. And during the treatment, if the patient is still getting infection, then we can also check immunoglobulin levels as well.
Sir,
Once the treatment starts, disease is in control, you have a good lymphocytes, then immunoglobulin level automatically picks up. Until unless you are giving rituximab. When you have completed rituximab and still you have infection, then you can also check immunoglobulin level. So based on means clinical acumen and the risk profile of the patient and clinical condition of the patient. If IgG levels, as said, more less than 400, or if the patient is still having infections even with the IgG level which are normal enough, then we can still give IVIG. It really helps.
Roshni, the
So,
next.
so how many slides more are there, Dr. Sadamni? Are we
I think three more. So it's
okay?
just the guidelines.
Okay.
The patient says we have to go for annual influenza vaccine, pneumococcal vaccine, and also the herpes zoster vaccination for the adult patient, or especially for the patients who are being treated with the BTKI, and for respiratory syncytial virus if we can provide them. Next one. These are the time periods when they have said we have to immunize the patient. Next. I think already this question has been taken up when to if whether we have to give the immunoglobulin therapy regularly or sporadically. In blood, there is an article which next one, Roshan. I think regular IVIG treatment as per this journal, they say does not reduce the risk of serious infections. So I think whenever the patient is having serious infections, we can check the immunoglobulin levels. If the patient is having low immunoglobulin, we can give for the IVIG. Next one. So this question is that as we know that with BTK inhibitors, the entire scenario for CLL has been changed. So what is your experience of infection with the BTK inhibitors? Have you seen the grade 3, grade 4 infections with those, or it has come down?
Okay, so single agent BTK inhibitors or combination with rituximab?
It single agent.
Single agent infection risks are quite low with all kind of prophylaxis. So we have not seen serious infections with BTK inhibitors when given as a single agent. But with rituximab, we do see this kind of infections. But still, I believe with appropriate care and appropriate prophylaxis, so these are very less and not life-threatening, so not grade 3, grade 4.
Roshni, the next one. So this article also showed that with the BTK inhibitors, we have seen a very less serious complications. So BTK inhibitors are very safe to be given for the CLL patients. Last slide. So what we learned today, just to see, though CLL with TP53 mutation necessitates the starting treatment only, but as per the indication, but still the disease biology is very aggressive. And CLL results in an immunocompromised state of the patient with cryptococcal meningitis is a very rare presentation of the patient, but it requires that the treatment has to be started. High degree of clinical suspicion and early intervention is the key to the better outcome. Thank you.
Hello.
Thank you, Dr. Sadamni. So before concluding, we'll just take a few questions from the chat box. One of the participants have asked, "Good evening, sir, Dr. Anita M." She says that one of her patient was diagnosed with CLL 5 years back and is kept under observation. So is it okay to keep the patient without treatment for such a long time? So, Dr. Anita, yes, if we have particular indications, the physician, the hematologist has to assess, and then we decide whether to treat or not, even if the duration is long. So, just Dr. Kunal and Dr. Viswajit, just one, two last questions from the chat box. One is when to do a TP53 assessment, whether just when we are planning to start a therapy or even when we are just putting the patient on follow up. Dr. Kunal, if you could give your inputs.
Yeah. So, when you are starting and when you have a means patient upfront, then better to check with the fish and NGS upfront. You do investigations upfront for all the mutations possible or cytogenetic abnormality. Then, if the patient after remission relapse or it is a progressive disease, then you can also check if there is any new abnormality added in course of the treatment. So this is my approach in general.
Dr. Biswar, do you beg to differ or do you follow the same approach?
Yeah, so we just do basing on the finances. If the patient is affordable, we do at the baseline also. And it means if the patient is not affordable and still treatment is not indicated, we generally do at the time when the disease progression, at the time of disease progression.
Great. Yes. So definitely before starting therapy, we have to do TP53. At the time of diagnosis, it should be done, but it's subject to the finances as well. The last question from the chat box is, should we is do we have to address the neutropenia while the patient is on BTK inhibitor? Suppose we say ANC is less than 500, or the patient is not having any fever. So besides the prophylaxis, is there any role of growth factors they have asked? Dr. Kunal, if you could.
So suppose the patient has persistent neutropenia, which is lying less than 500 numbers, 250 or less than that, then you can use BCSF. Patient is super stable. There is nothing else in the neutropenia 9,500 to 1,000 range. Then we can also wait for the BTK inhibitors to work. Even after BTK inhibitors, will now history of current medication, definitely yes.
Thank you so much, Dr. Kunal. So I think we have had a wonderful session today. So much of updates and such an interesting case by Dr. Sadamni. I thank Dr. Dr. Varun Bafna for such an explicit presentation on all the CLL updates, and Dr. Sadamni for such a nice illustrious presentation of her case. I thank Dr. Kunal and Dr. Biswajit for sparing their important precious time in enlightening us as well as all the audience. A big thanks on behalf of the team IAIO. I, Dr. Tushar Pandey, takes off. All then, good
Thank
night,
you.
everyone. Yeah.
Thank you.
So thank you for this beautiful case and all the this discussion, multiple discussion.